Good evening and a warm welcome to today's webinar. This is the fourth and final session from the series Sports Cardiology, and we are delighted to have you all join us for an insightful webinar, Exercise Prescription in Heart Disease and Return to Play. This session promises to be both educational and engaging as we dive deep into the clinical challenges and real-world insights surrounding heart disease. Ma'am, we are truly honored to have you with us, ma'am. Dr. Veenu, ma'am, consultant interventional cardiologist, Mysore, with a decade of experience, taking her valuable time and investing in us younger doctors and explaining the subject very engaging and understandable. We look forward to an enriching discussion that enhances our understanding. Without further ado, I now invite Dr. Veenu, ma'am, to take us through today's webinar. Over to you, ma'am.
Thank you so much, Dr. Revat. So I'll start sharing my slides. Are my slides visible?
Yes, ma'am, it's visible.
Okay, so we'll go ahead. So good evening, everyone. So the last of the session today. So just as we start again, another recap. So basically, I have already told that, the role of a sports cardiologist is to find out exercise-induced cardiac remodeling from CV pathology, first thing that we already saw. Then we look at highly active people or competitive athletes. When they are symptomatic, we evaluate them and find out whether they have CV disease. So all this we have finished. Sudden cardiac death we have prevented. Now we have come to the stage of giving them exercise prescription. That is the last one. So we already know, and we've gone through this slide previously, just for us to know that each exercise has a certain amount of dynamic component and a certain amount of static component. As the dynamic and static component increases, maximum amount of changes happen in the heart. And some people who are genetically prone have more changes in the heart when compared to those who don't have those genetic changes. So when we look at athletes who are symptomatic, we are going to be stratifying them and getting an array of investigations from a CT coronary angiogram to an MRI to a CPET and a myocardial perfusion study to finally find out what the pathology is. And then accordingly, we will suggest to them whether they can actually go ahead with any form of sports or not. So pre-participation screening is very important as we know it. So significantly reduces the risk of sudden cardiac death in athletes. So whether once we have done a screening, whether we can license them to practice sport or should we modify the type of sport that they are going to do or some disease related intervention which can actually help them go back to the sport. These are what we will come to by the end of the pre-participation screening. Then we will look at recommendations for professional athletes based on their personal history, physical examination, and ECG. So when we look at young athletes are those who are less than 35 years of age. So there are questionnaires available which will ask them clearly about their family history, the personal history, and any past complaints that they've had. Then we will do a physical examination and an ECG. Echo may or may not be needed depending on what we find on ECG. If at all we find some abnormalities in these set of patients, like maybe a long QT or so, based on that, we will further take investigations which will come to the correct diagnosis by the end of it. In master athletes, that is 35 years and above, or what we call the older athletes, there is always a risk of coronary artery disease. So we have to do the 10-year risk stratification either using QRIS score or score 2 risk score or an ASCVD risk score. And based on the risk stratification, whether they come under mild, moderate, or high risk, we will evaluate them further depending on their symptomatology also. And based on what we find, we can suggest to them whether they can go ahead with sports, high intensity, moderate intensity, or low intensity. So these are some aspects that we learned. So now we are actually looking at somebody who already has a cardiac pathology. That is today's set of talk, whether we are going to give them exercise prescription or not. So many a times, let's say around 20, 30 years back, when somebody develops myocardial infarction or some form of LV dysfunction, most of the times it used to be only bed rest. So they used to say bed rest for almost 6 weeks. So those years are gone. Why? Because we have enough studies. So I have put one study here, CROSS 2, which was done in 4,000 patients. And they looked at the effectiveness of cardiac rehabilitation participation after a acute coronary syndrome and after coronary artery bypass surgery in actual clinical practice. And they very clearly found that it reduces total mortality under any condition when it is prescribed to patients with coronary artery disease. Hence, the need for us to give exercise prescription to all our patients with coronary artery disease, depending on what their situation is. So, that is the crux of this talk today. So here we can see a graph wherein we can look at the 36-month event rate. That is mainly we are talking about mortality along the y-axis, and along the x-axis you have the duration of activity, physical activity. That is, one is both hours per week as well as metabolic equivalent. That is the intensity of activity per week. And we clearly see that the blue line is the cardiovascular mortality, and the red line is the all cause mortality. When we look at both, there is an decremental decrease in the mortality as there is an increase in the exercise. So, exercise not only reduces cardiovascular mortality in coronary artery disease patient, but it also reduces all cause mortality. So, all forms of mortality comes down. And if you actually look at patients who are highly active, they have 50% reduction in mortality when compared to those who are inactive. So this is strong enough evidence for us to say that though somebody has coronary artery disease or cardiovascular disease, it is very important for us to keep their fitness level high in order to reduce mortality. So here, just for us to have a thinking, when we look at a patient, we want to know what level of activity they are in, whether it is low, medium, or high. So let's say even basketball, handball, or soccer, if it is just adapted as in symptom limited, it is still considered a low intensity activity because they are not stressing them beyond a certain point. But if it is competitive, then it becomes a high intensity activity. So most of the high intensity activity are boxing, weightlifting, wrestling, and competitive basketball, and all this biathlon, triathlon, long distance cycling, all this come under high intensity sports. So, based on all these studies, what the WHO recommends according to the 2020 guidelines. So, for adults, we expect them to do 150 to 300 minutes of moderate intensity aerobic physical activity per week. Or if it is vigorous high intensity activity, 75 minutes to 150 minutes is fine. This is basically a minimum recommendation that is given for in order to have better cardiovascular outcome. For people who are more than 65 years, this is for adults. For more than 65 years, even 3 days per week of varied multi-component, they will need even balance training and other things. So they need at least 3 days per week of activity. If they want additional benefit, some amount of strength training has to be added for 2 days a week. So this is the type of exercise prescription we would minimum give. Based on what the patient wants, then we can grade it whether we want to go higher than this or not. So this is how we go about counseling physical activity and recreational sports for patients. So if we are thinking of 150 minutes of activity, first we will look at the individual, whether they have any cardiovascular risk factors or not. If there is no risk factor, no other problems, then we are just going to give them the lifestyle coach or prescription with no restriction. They can go ahead with whatever level of activity they want. Second is an individual who already has risk factors. So here we have to use our risk stratification criteria and find out whether they come under low, moderate, or high risk. Most of the risk scores are available on the net. So we just have to put in the parameters and the risk is calculated. And if they come under low risk, that is less than 7% of 10-year risk of developing any of the cardiovascular disease, then there is not much for us to do. Patient is also asymptomatic. We suggest to them that they have no restriction and can go ahead with full activity of whatever they want to do. When a person already comes under the moderate to high risk, then, or we are suspecting that the person has some cardiovascular disease, we have to go ahead with evaluation. So the evaluation includes history, physical examination, and ECG. Based on whether they have high risk, we have to go ahead further with an echocardiogram, treadmill test, or if treadmill test is not testing the full potential of an athlete, then we may, and the athlete is symptomatic, we have to go ahead with a CT coronary angiogram or a regular coronary angiogram. So if all of our full test profile is negative, there is no restriction and they can go ahead with even high intensity activity. If they are showing some high risk features, either on ECG, echo, or in the CT angiogram, any of those, then we can't suggest them for high intensity activity. We will have to tailor it down depending on what is recommended for them or what is recommended according to what conditions they have. So, what are the benefits of physical activity? One is in patients who already have risk factors, it actually lowers the risk factor. So, if they have hypertension, it reduces blood pressure, reduces cholesterol levels. So, overall, it has good effects on the risk factor, and it also complements the medical treatment that we are going to be giving to the patient. So, exercise has to be a part of prescription for any patient who comes to us. So now we'll look at the special populations of of different types of cardiovascular disease. This we had already kind of discussed previously. So in coronary anomalies is one of the main reasons for sudden cardiac death. So these patients, basically there will be compression of coronary arteries when they have exertion in between the aorta and the pulmonary artery. So they'll have recurrent ischemia and fibrosis. So these are high risk population. Unless we are going to correct the anomaly or there is no fibrosis in the cardiac MRI, they are only allowed for low intensity activity. So we had already seen the low, medium and high intensity activity. Based on that, we can tell them that this is your exercise prescription. You can't go beyond this level of activity, and whatever they do has to be graded. Next is mitral valve prolapse. So in a patient with mitral valve prolapse who is symptomatic, we are going to be doing Holter examination to see for arrhythmias, treadmill test to see if they are developing any ischemia during the test, or cardiac MRI to find out if they have infrabasal fibrosis, which is seen in mitral valve prolapse patients. So these are all high risk features, and once they have high risk features, they can't be allowed for both recreational or competitive sports. So only low intensity activity is allowed. So these are patients whom we are going to, the ECG is showing some changes of T inversion and inferior leads. There is some long QT or bileaflet mitral valve prolapse. Both leaflets are prolapsing with severe mitral regurgitation, or a family history of sudden cardiac death, documented arrhythmias, the fibrosis seen on a cardiac MR, or severe LV dysfunction. So these are all the high risk features wherein we can allow this mitral valve prolapse patient to only do a low intensity activity. When we look at hypertrophic cardiomyopathy, high risk of sudden cardiac death, if there is, like somebody who already has a family history of sudden cardiac death, or the type of mutation, like a troponin T mutation, can lead to high incidence of sudden cardiac death. So, depending on the mutation, we can't allow them to go for high or moderate intensity. activity. And the type of sport also matters. In these patients, the start stop sports like a basketball or a football, wherein suddenly they have to run, stop. So the heart rate variations are too much. So those type of sport is generally not recommended, wherein a low intensity sport may be allowed. Their personal history, family history, and clinical severity have to be looked into. Any syncope has to be taken seriously, or any resuscitated sudden cardiac arrest. Also, they are allowed only for low intensity activity. Such patients also need an ICD. Then, when we look at the echo, we look at the LV thickness. If the LV thickness is more than 30 mm, definitely they have a high risk of sudden cardiac death, as well as they are not they should not be allowed for anything more than low intensity activity. If the LVOT gradient is more than 30 at rest, they are also not allowed. If the LA diameter is increased, then also they are prone for arrhythmias, which will be life threatening. Hence, we can't allow them for moderate or high intensity activity. Arrhythmogenic cardiomyopathy, once it is diagnosed, they are generally very prone for arrhythmias, and they are also allowed only for low intensity activity. So it can be picked up either by Holter or from ECGs, wherein they will have epsilon waves. And competitive sports is definitely a no for arrhythmogenic cardiomyopathy. We will see a lot of dilated cardiomyopathy in our day-to-day routine. So only those who are asymptomatic and have low risk criteria can be allowed for competitive sports or moderate intensity sports. So who are these who have low risk? One is they have only mildly reduced ejection fraction. They have absence of any of the ventricular arrhythmias on a Holter monitoring or on a exercise testing, and MRI doesn't show any fibrosis, and ability to increase ejection fraction by 10 to 15% during exercise. So we can do a stress echocardiography and see if the ejection fraction improves. And there should be no evidence of lamin AC or filament C mutation on the genetic testing, because they are prone for arrhythmias and sudden cardiac death. When we look at, we know that during COVID, we saw so many patients with myocarditis. So during the acute phase, they are not allowed. So generally, a myocarditis, it depends on what type it is. Some of the myocarditis settles within 4 weeks to 6 weeks. There are some myocarditis which have an indolent course and may go on for 3 months also. So once in the acute phase, they are only allowed for low activity. Once they get into the resolving phase, if they are asymptomatic, we have to look at biomarkers, that is troponin, NT-proBNP, and CRP. They should be normal. Then we are looking at LV and the RV function being normal, and we do a cardiac MRI which is showing no evidence of myocardial fibrosis. So there is no late gadolinium enhancement or no arrhythmias on exercise. Only then we can allow them for moderate to high intensity activity. Many a times there are so many sudden cardiac deaths which are unexplained, but the person might have had a flu or a viral fever sometime back. So they may not be evaluated for myocarditis. So these are the type of sudden cardiac death that will be missing if we have not diagnosed myocarditis. So after viral fever, we should be careful enough to understand whether the person had myocarditis or not before we go ahead with prescribing high intensity sports for them. In a person with supraventricular tachycardia, just plain supraventricular tachycardia is okay. But if they have pre-excitation, they are prone for ventricular arrhythmias and sudden cardiac death. So it is important for us to evaluate these patients with SVT, whether they are prone for ventricular arrhythmias or not. And it would be better for us to put them through a radiofrequency ablation and test them over a treadmill or a CPET before we send them for high intensity or moderate intensity activity. Long QT and Brugada, they are not allowed for high intensity activity. They may need an ICD depending on risk factors, whether they've had a syncope, pre-syncope, or any family history of sudden cardiac death. Complex congenital heart disease with cyanosis, they are only allowed for low intensity activity. We can't even gradedly increase their activity. So, what are the contraindications for exercise in a person who already has cardiovascular disease? One is if they are decompensated heart failure. So, let's say they are in class 3, class 4 with orthopnea at night, definitely we can't allow them to go for any form of activity. Next is if they have any unstable angina. So, somebody who was walking for 1 kilometer every day is developing angina when they walk for 500 meters every day, then it is an unstable plaque sitting there. In those cases, we are not going to give any exercise prescription till the problem is sorted out. They have to go for an angiogram and get the unstable plaque fixed. After that, we can give them a exercise prescription. Somebody who is having ongoing angina, this is what we see most of the times as a mistake when somebody develops an acute coronary syndrome having ongoing angina and they are not put under rest. They will walk to the hospital. They will take they take it easy because sometimes diabetics may not have chest pain. Those are the times when they have arrhythmias and sudden cardiac death. So any person with ongoing angina is not allowed any activity. Then I have already shown that active myocarditis or pericarditis, they are not allowed for activity. A, in the valvular heart disease, a person with symptomatic severe aortic stenosis should not be allowed for any activity unless the aortic stenosis is corrected. In other types of valvular heart disease like regurgitant lesions, generally if there is LV dysfunction, then only a low intensity activity should be allowed. Third degree AV block, naturally their heart rate will be low, so only low intensity activity. If they have orthostatic hypotension, which is very significant, they will fall as soon as they stand. So naturally activity cannot be allowed for them. And resting heart rate greater than 120 is then again when the activity starts, their heart rate is going to go beyond 160, 170, and hence it is not it's better for us to for them to go for a low intensity activity till the reason for the high heart rate is identified and corrected. So when we look at blood pressure, generally 180, 110 is a cutoff. So it's still a relative contraindication only. We can allow them to do low intensity activity. So when we look at patients with coronary artery disease, which is the most common type of problem that we will be encountering day in and day out in the OPD, chronic stable coronary artery disease, we will put them through graded exercise testing. So I will be showing how we go about with the graded exercise testing. In unstable patients, we know there is no exercise till the unstable plaque is sorted out. If it is patient post bypass or post PTCA, complete revascularization is done, and we waited for the period of time when they are prone for arrhythmia, then we can again put them to graded exercise testing. So when we look at graded exercise testing, if we have a CPET, I know I already told in the previous talk that CPET is not available in Mysore, but Bangalore also only few of the hospitals have it for evaluating patients who are candidates for heart or lung transplant. So if we have CPET, then we can look at the VO2 max. For a light intensity activity, VO2 max less than 40. 40 to 69 is moderate intensity. 70 to 85 is high. And very high intensity is greater than 85% of somebody's VO2 max. Then we look at the maximum heart rate. Maximum heart rate is calculated as 220 minus the age. So percentage of that maximum heart rate that we reach. So if it is less than 55%, it is only low intensity. 55 to 74% is moderate intensity. 75 to 90 is high intensity, and more than 90% is very high intensity. When we looked at heart rate reserve, it is considered one of the best indicators for exercise intensity and also fitness. So heart rate reserve is basically maximum heart rate minus the resting heart rate, percentage of that. So if it is less than 40%, it is light. 40 to 69% is moderate, and 70 to 85% is high intensity activity. So many a times, sports people will come and ask about what heart rate to maintain. So it depends on each athlete or each person. So a very well trained person who's doing a marathon may have a heart rate which is only in the moderate intensity level. So for them, that marathon may be just moderate intensity because they have trained their heart and themselves very well. So this is just the grading based on some normograms that we use. So there is the 6-minute walk test which we use for most of our cardiac patients. So these are used uh, basically the other type of tests that we do will need expertise to see. A 6-minute walk test doesn't need any extra expertise. We can keep two cones 10 meters apart and give a 6-minute time for the patient to go around that place and see how much they have walked. And there are normograms available for a person with certain height and weight. And depending on the normograms, we can say whether they have achieved 80% of the distance that they should have covered or 100%. So this will only tell us about the mild and moderate intensity level of activity. Then we have this Borg scale of perceived exertion. So I'll just show a picture of that. So based on that, we will say whether person has exerted too much. Then, so for an untrained person, even a small activity may look like high intensity depending on the exertion, perceived exertion level. But for a trained person, even a high intensity activity will be low because they have trained themselves that much, and there is a lot of adaptations that has happened in the heart. So, to be simple, we can say that if somebody is doing an activity and able to sing, like a walk, a brisk walk, and able to sing, then it is low intensity activity. If they can just form sentences but can't sing, is moderate intensity activity. If they are unable to talk even, then it is a high intensity activity for that person. So this is the Borg scale. So based on the level of exertion, if they don't feel any exertion, so most of the watches will ask whether you feel green, yellow, orange, or red. That is basically how you perceive the exertion to be. So based on that, you can tell whether you hardly felt any exertion, then it is green. If you felt light exertion but you were able to still talk, then it is yellow. And orange is some breathing difficulty but can converse to some extent. You can't complete a full sentence, then it's orange. Can't talk at all or maximum exertion with respect to body ache and everything, then it is red, that is high exertion. So this is the scale which they use to find out what type of exertion the person has gone. So this is how we prescribe the exercise for cardiac rehabilitation. So first we assess the physical activity of the person with respect to aerobic resistance and physical activity. Either we can use different modalities like what I have already shown. For strength training, we will make them lift some weights, at least one repetition, and then see how they do. So based on this, we will set up a FITTP that is frequency, what frequency they are doing, what intensity they are doing, what is the time duration, what is the type of activity, volume of activity, and progression. So this much we will make a note and we will prescribe do this much amount. So after they have done for a certain period of time, we are going to reassess, looking at what is their level of exertion and all those parameters that we will look at, heart rate reserve, or it may be target heart rate or percentage of the maximum heart rate. So those aspects we will, and the workload. Based on that, we will increase the grade of activity. So it will all be scientific so that we gradedly go ahead with increasing the activity in order to improve their long term survival and also quality of life. So, just a few cases that we had already kind of discussed previously, just to get these points across for us. So, there is this 33-year-old male who's a smoker and has a strong family history. He's a marathoner and does regular strength training. So he develops chest discomfort suddenly during strength training in the gym. He comes for evaluation after 1 week because every day when he goes to the gym and does the same level of strength training, he develops chest pain and he can't do anything further. So then ECG showed myocardial infarction, troponin I was positive, echo showed lateral wall hypokinesia, ejection fraction around 50. So angiogram done showed a D1 ostial occlusion, which can't be revascularized because it is a small artery, and uh, revascularizing the D1 will actually compromise the left anterior descending artery, which is a larger artery, and hence he was put on medical management. So this person, after a period of 6 weeks, im- improve started going back to gym, was on high dose of statins, and didn't develop any further angina. He increased his gym training and everything in a graded way, monitoring his heart rate also to maintain it around 75% of his target heart rate. And after that, he wanted to run a marathon, for which we put him through a treadmill test. And at around 14 to 16 mets, he started developing some STT changes, and he was also very symptomatic. So I said he is not fit for a marathon yet. So it is only mild to moderate activity that he can continue, and he's on that prescription now for many years, in fact, now. So case two is a 26-year-old lady who does regular strength training and walking, develops palpitation, which settles after 20 minutes. And her sports watch shows a heart rate of 220. So definitely it is not normal, it is abnormal. And she had sweating and complaints, dizziness during that time. So she reached the hospital, ECG echo normal, but troponin I was positive, so coronary angiogram was done, which was also normal. On reviewing the ECG, she had mild QT prolongation. So probably that is the trigger factor for the tachycardia. So potassium was 3.3. We thought we will correct the potassium and then repeat the ECG. So when she came back the next time, the potassium was still low. And then we found out that she had a potassium loss in the urine. It is Liddle syndrome. And family screening showed four other people in the family having the same type of disorder. So they are on regular potassium supplements. And if the potassium supplements are given and their potassium is corrected, then the QTC will be normal and they can be allowed for mild to moderate activity. So next is Mr. B, who's a 26-year-old with palpitation during badminton on and off since 2 months, no syncope. Feels tired during the episode. ECG echo and TMT were normal. So we decided to put him through a Holter examination and asked him to play badminton during that time. So he had a tournament luckily at the same time. So this is a Holter examination which shows that during the tournament when he developed the palpitation, it is a supraventricular tachycardia. So the rate is going up to almost 250 and all that. But he is able to maintain cardiac output even at a 250 heart rate. And in this case, we definitely would not advise him to go ahead with tennis unless go ahead with badminton unless he gets this rectified, because 250 heart rate is too high and it can be dangerous for for an competitive athlete. So that way, now he's gone for a RF ablation. So after RF ablation, we can put him through a Holter and again put him through the same badminton tournament and then see if he develops. If he is not developing, then we can suggest that he can go ahead with his competitive training of badminton. So thank you. That is the end of the session. If
Thank
there
you,
are
ma'am.
any questions, I'm
Thank you.
ready to take.
Thank you, ma'am. There are any questions, please?
It was very much interesting, madam.
Yes, sir.
Uh, What about this wearable devices? How accurate, madam, while doing this exercise or while even doing running and
It that is what, sir. It depends on what type of wearables we are using.
Mhm,
So, and what type of, let's say, we are using a watch. So, how well the watch is fit to the hand, all that matters. Generally, if it is a good device and good attachment, the accuracy is up to 85 to 90%.
mhm,
But some of them also have the chest bands, which will
mm,
monitor ECG. Those are much, much more accurate, and they are actually can be stored in the web. So
mm.
they are on remote monitoring. So if there is remote monitoring, then they are much, much more accurate than just the wearables that we are talking about.
Okay, nice, madam. Even we have necklace now, wearable devices.
Yeah. So
Okay.
many of them actually
Mm,
record the ECG. So
mm.
those which record the ECG actually are very, very good.
Okay, madam.
Um, in fact, there was one patient who had an Apple Watch.
Mm,
During yoga, she's a case of dilated cardiomyopathy. On had stopped treatment in between for some time. When she was doing yoga, she developed palpitation, and she was lying down on the bed. And she called telling, I'm having palpitation. What should I do? I
mm,
said, you just send me the ECG from your Apple Watch.
okay.
So she sent the ECG, and that was an SVT with a heart rate of 180. I said, you go to the nearest hospital and have an adenosine. You have to do it immediately. So that was rectified and taken care of.
Very
So
nice, madam.
that way, if they have ECG monitoring and other things, it
Uh,
really helps.
Helpful.
Yeah, for remote monitoring and everything.
Well, if the person want to do exercise, madam, you start
Hmm.
want to start exercise, do you recommend he should undergo cardiac evaluations? Healthy individual.
Yes, sir.
Mm.
Anybody, especially if they are going for high
High
intensity
intensity.
activity or competitive sports, it is definitely indicated. If
Mm.
it is not competitive sports, just a moderate intensity, it may not be indicated unless
Mm.
they are symptomatic.
Symptomatic. Mm.
Mm. High intensity and competitive sports, they have to have a screening, sir, before they go ahead. Like many of them who go to the Himalayas and all,
Mm. Mm. They have
even
to.
for religious purposes,
Mm-hmm.
they have to have a clear-cut screening because that is high intensity.
Mm-hmm.
So many a times they will only do a very basic screening, and doctors also many a times
Mm.
don't know the intensity of activity. They will just give fitness, just
Mm-hmm.
talking to the patient. It is not so. Because
Mm.
it is high intensity activity, they have to train themselves in a graded
Mm.
way before they go for the high intensity activity, and
Mm.
also have their regular ECG, if need be, treadmill testing or CT/CAG before they go for high intensity activity.
So mainly ECG and CT, CAG, coronary angiogram.
No, so coronary angiogram if they are symptomatic.
Symptom only ECG,
Symptom
TMT.
ECG, echo TMT, we can put them through,
Okay,
and
okay,
they have to have some training before they go,
okay, madam.
because many a times heart can't take that much activity. There
Yes,
was
madam.
one patient who went for Chardham Yatra,
Mm.
and she had stress cardiomyopathy because of the physical stress that she put
Mm.
the heart through, and
Mm.
half of the LV was filled with thrombus.
Oh my God. Mm.
Thankfully, it went only to the leg, and she had
Mm.
monoparesis.
Mm.
Then that anyway, embolectomy was done, and the leg was saved. And because half the LV was full of clot, and LV was recovering now, stress
Mm.
cardiomyopathy, we
Mm.
thought all of it is going to go to the CNS and cause
Mm.
a stroke.
Mm.
But because of the lytics that were given for the
Mm.
leg,
Mm.
that also got lysed,
Okay,
and
very,
she didn't have any further embolic phenomenon.
very nice, madam.
But
Many.
after 2 weeks, she recovered completely. The LV recovered.
Mm.
That is
ma-
because she did unaccustomed.
mm. Many doctors don't have even awareness about these things, madam. Just they do
Yeah.
ECG and all. So I
Hmm.
think we should this knowledge should be disseminated everywhere. Actually, this for sports
Hmm.
cardiology is very interesting.
Yes, sir.
We should do a lot of program regarding this, and these videos should spread everywhere so that they will get a knowledge. Young doctors,
Yes, sir.
yes, madam. I think there are questions are there.
One question is there, sir. Please explain 6-minute walk test. So 6-minute walk test normally we do for heart failure patients or for patients with pulmonary artery hypertension in clinical setup. Otherwise, if we want to test anybody's functional capacity in a outside clinic, it is very easy to do. So first thing what we will do is we will keep two cones 10 meters apart so that we can measure it. And before we start the test, we will check the pulse, BP, and saturation of the patient, height and weight of the patient. So after we have done that, we let them walk for 6 minutes. We will also put a chair on both ends or in between, because if it is a patient who is very sick with pulmonary artery hypertension, they may not be able to walk continuously. So they may want to sit in between. So all that is allowed. So, and then by the end of 6 minutes, we will calculate how many meters they have walked. And end of 6 minutes, we will check their pulse, BP, and saturation again. So, based on normograms, which are there for their height and weight and for their age, we will look at how much percentage of that they have achieved. If they are achieving more than 80%, is very good. If they are achieving less than 80%, we can also use it as a tool to see their progress. So if a heart failure patient could walk only, let's say 250 meters or less, they are actually candidates for heart transplant. Similarly, for a patient with PAH or lung interstitial lung disease, their level of activity also predicts whether they are candidates for lung transplant. If they can walk more than 250 meters, then we keep a watch. Let's say I did a 6-minute walk test this month, and I'm repeating after the next in the next month. And their walk distance, saturation, heart rate, everything, if it improves with respect to activity, then we know that whatever treatment we are giving is working for the patient. So this is the in the clinical setting. Otherwise, with respect to sports prescription, in that way, it is only going to help us to see what level of activity they are reaching without a treadmill test or a CPET, and we can tell them to do a little more than what they are doing. So graded increase in the activity. And the normograms are available on the internet for us to, if we can just enter what the patient has achieved, and it will give you the percentage of how much the patient has walked according to their normograms. Any role of cardiac synchronization therapy in heart failure with preserved? There is no role for CRT in heart failure with preserved ejection fraction. It is only for reduced ejection fraction. When a patient has wide QRS complex, mainly an LBBB, if they have more than 150 milliseconds, it is class 1 indication. If they have between 120 to 150 milliseconds, it is considered as a class 2A indication. For preserved ejection fraction, it is not going to help at all.
Are there any more
So that
questions?
is it.
Uh, Thank you, ma'am. It was
Okay, fine.
very enriching session.
Yeah.
You explained about everything, activity and level of activity for each diseases, MR, MVP, HOCM, cardiomyopathies, everything, ma'am. And even you explained different cases and how they present and what to be done. It was very enriching, ma'am. I thank you behalf of everyone who has attended this session, ma'am. It is very informative. And for a young budding doctor like me, it is changing. It's very changing
Yeah.
for me to look at the ECGs and all those things and how exercise affects. Thank you very much, ma'am. I thank you, Remedy International Skill Bridge, for giving this session platform for learning about exercise cardiology, sports cardiology. Thank you, ma'am.
Thank you,
Thank you, sir.
everyone. So, yeah,
Thank you, ma'am. Thank you for the session.
yeah, yeah, sure.
Thank you, sir.